Hi, good afternoon, everyone, and thanks for coming to the Ask the Expert webinar. My name is Jyothi Tirumalasetty, and I'm a clinical assistant professor here at the Stanford Sean Parker Center for Allergy and Asthma Research. And our topic today will be eosinophilic esophagitis. And you might hear me say EOE for short because it is kind of a tongue twister. So we're going to go over an overview of eosinophilic esophagitis, what it is, what our diagnosis often looks like, and also we'll go over some treatments and some of the studies that we're doing here related to EOE. And I will start by defining eosinophilic esophagitis. It's a chronic immune-mediated condition of the esophagus that causes esophageal dysfunction. And inflammation in the esophagus is driven by allergic cells known as eosinophils, and also by a specific subset of T cells known as Th2 type T cells. And these T cells are really what drive inflammation in many allergic diseases as well as EOE. And in EOE, we also know that allergen exposure activates the inflammatory response as well. And so it's interesting because EOE doesn't fall into our traditional IgE mediated or immediate type food allergies that result in anaphylaxis. It's more of a mixed type condition where we see food allergens playing a role and also chronic inflammation that can happen over time. And so we would put this kind of in the middle here in the mixed type spectrum of food allergy. And so EOE has been rising in prevalence and incidence over the past 2 decades. And the prevalence is approximately 34.4 per 100,000 worldwide. There's a male predominance with this disease, and the male to female ratio is approaching about 3 to 1. And we know that this condition affects adults more than children. There are certain risk factors that we've identified with EOE, and some of these include things like having a first degree relative with EOE, um, if uh, if you're male and you have a history of allergies or you're atopic, that could also be a risk factor. Being on oral immunotherapy or sublingual immunotherapy could also be a potential risk factor. And also, certain early life exposures have been linked with an increased risk of EOE, such as cesarean birth and early exposure to antibiotics and formula. And I want to stress that these are not cause and effect, but just some certain factors or risk factors that have been linked with EOE. And as I had mentioned in the previous slide, being atopic or having a history of allergies is a risk factor. And the majority of our patients with EOE have a history of allergies or that atopic phenotype. And that includes conditions such as atopic dermatitis, allergic asthma, allergic rhinitis, and also IgE mediated food allergies. And it's interesting because environmental or aeroallergen exposure is associated with the development of EOE. And the diagnosis of EOE can actually vary by season. And we see higher rates of diagnosis when outdoor aeroallergen levels or pollen levels are high. So that could be summer or fall, depending on where you live, or maybe spring. And we often see that in adults, environmental allergies actually precede the diagnosis of EOE. So there's definitely an interesting connection between EOE and environmental allergies. Now I'd like to talk a little bit about diagnostic criteria. And so typically a diagnosis of EOE would look at several things, including clinical symptoms, histologic changes more on a tissue level from possibly biopsies, and also endoscopic findings. So findings that we would find on an EGD or esophagogastroduodenoscopy. That's a mouthful, so I'll abbreviate it to EGD. And so this procedure is used to help diagnose and monitor EOE. It is an invasive procedure and requires sedation. It's typically performed in a medical center or a hospital setting, and the endoscope or tube has a camera on the end of it that helps to visualize the esophagus. And it's also used in other conditions to visualize the stomach as well. And so with this endoscope, we can also obtain samples, which is very important and helpful in diagnosing EOE as well. And the risk for an EGD include things like having a sore throat afterward, being tired after getting the sedation for the procedure, and rarely things like a perforation or tear would occur. And so this procedure is typically very safe and very well tolerated in most. And so some of our diagnostic criteria include symptoms of esophageal dysfunction, and I will talk about those in more detail in a few minutes. But things like trouble swallowing um, or food getting stuck could be some symptoms. And we also see an eosinophil predominant inflammation on esophageal biopsy. And so that would be more specifically greater than or equal to 15 eosinophils per high power field on the biopsy. And we also would want to make sure we did a thorough history and exclude other causes that may be responsible for the symptoms or the eosinophilia. And so these are just some conditions. It's not a complete list, but just some other common causes of esophageal eosinophilia. And those include GERD or gastroesophageal reflux disease, a condition called achalasia, which may cause trouble swallowing, Crohn's disease, which is an autoimmune inflammatory bowel condition, celiac disease, which involves gluten intolerance, and even drug reactions can increase eosinophils in the esophagus. And finally, connective tissue disorders or autoimmune disorders can also increase eosinophils in the esophagus. So these are all things to really keep in mind when we're seeing increased eosinophils in the esophagus. Now I'm going to talk a little bit about the histologic features. So these would be things that we would see on our biopsy, and that would include things like smooth muscle hypertrophy, collagen deposition, lamina propria fibrosis, and also angiogenesis. And so these things may not be present at diagnosis, but if untreated, they can often progress. And sometimes we can see tissue remodeling, and that tissue remodeling can lead to symptoms and sometimes complications as well. And some of those complications might be stenosis or narrowing of the esophagus in certain areas, decreased motility or dysmotility of the esophagus, narrowing of the inside or narrowing of the lumen of the esophagus, and also food getting stuck or food impaction. And those symptoms don't occur in all patients, but again, those are just some symptoms of eosinophilic esophagitis once it has progressed. And then if we think about what's going on as far as symptoms, we can also correlate that to the appearance that we see on the EGD or endoscopic appearance. And so some things that we might see on an EGD would be linear furrows, mucosal rings, a smaller caliber esophagus, strictures or narrowing of certain areas of the esophagus. And then you can see here on the lower right-hand side that there can be plaques or exudates as well that are present. And we can kind of compare these for pictures on the lower right-hand side to the normal esophagus on the top. And again, these changes and symptoms don't occur in everyone, But I just wanted to give some examples of what can happen chronically with EOE in some of our patients. And so, as I had mentioned earlier, there are characteristic symptoms that we look for in EOE, and this can present differently in children compared to adults. In children, we tend to see symptoms like nausea and vomiting, picky eating, failure to thrive, or just overall not meeting our growth, height, and weight parameters, abdominal pain, and also heartburn. And in adults, we can also see heartburn, but we tend to see more food impaction or food getting stuck. We tend to see trouble swallowing or dysphagia. And also sometimes adults can present with chest pain as well. Now, I'd like to move on to some treatment options for eosinophilic esophagitis. And I'll go through four of them. So, elimination diets, topical steroids, proton pump inhibitors or PPIs, and our biologic called dupilumab, which is an anti-IL-4 RA biologic. And that medication has recently been approved. And so we'll go over all of those briefly. And so our first three treatment strategies that I mentioned, which include elimination diets, topical steroids, and proton pump inhibitors, are probably more considered first-line therapies. Since the dupilumab was recently approved, we are still incorporating how to use that biologic as far as our treatment guidelines. And I think we should have some new treatment guidelines out soon that help guide us. But typically, we look at our first three treatment strategies, and there's no specific order that we recommend using them in. There's no great studies that show that one should be used first. It really depends on patient preference and just what fits, the patient best and what seems to be the most effective. And regardless of which treatment option we use, it's really important to keep in mind that we need to kind of follow the course of the condition with frequent endoscopies to see if the treatment was efficacious or not. And so early on, I'd say when we started looking at best ways to treat EOE, we would often use either skin prick testing or A2P patch tests. So these are two different ways of testing for food allergies. And we would use these to help eliminate specific foods from the diet. And then we saw that some additional studies looking back at these methods found that it wasn't the most efficacious. Oops, sorry about that. It wasn't the most efficacious. And so we have new guidelines now that really don't recommend specific food allergy directed food elimination. And we find that this induces histologic remission in less than a third of adult patients. So we've really moved away from this method of food elimination, and we've moved more toward elimination diets. And I have here as an example, 6-food elimination diet, but there's many variations on this. And we can do also a 2-food elimination diet. So it could be avoiding milk and wheat, or a 4-food elimination diet. It's not based on allergy testing, but more based on these 6 foods, which we know are most likely to trigger EOE. And so with the 6 food, we would recommend avoiding cow's milk, egg, soy, wheat, peanuts, tree nuts, fish, and shellfish. And we eliminate those for 6 to 8 weeks. And this method has been shown to be efficacious and helps to induce histologic remission in about 74% of children. And so it can be difficult to avoid all of these foods. And that's why it's nice that we are able to modify this. And eventually, whether we choose a 2-food or a 4-food or a 6-food elimination diet, we do try to reintroduce these foods back into the diet one at a time. And we like to follow with endoscopy to make sure that we're not having a recurrence of eosinophilia and histologic changes that would be concerning for EOE coming back. And the other concern with six food elimination diet is that especially in our younger children who are maybe going to be more prone to food allergies, that restricting the diet could result in more IgE mediated or allergic reactions to foods that are more immediate. And so that is something that we should also be looking at while reintroducing foods, depending on how long it's been. And that might require some food allergy testing or food challenges to make sure that food allergies have not developed to those eliminated foods. So, briefly, elemental diets have also been used and have been successful in inducing histologic remission. And this is where you would consume non allergic amino acid based formula only and avoid all solid foods. This can also be modified, and some solid foods, maybe one or two, may be allowed. But again, this helps to significantly reduce symptoms. And we eventually do try to reintroduce foods one at a time. And again, this is also a challenging diet because it's very restrictive. And sometimes, if large amounts of tube feeding is required or feeding is required with the formula, we might need to put in a feeding tube. And so, again, there are advantages and disadvantages to elemental diets as well. So, topical steroids have also been used to treat eosinophilic esophagitis. And I'm going to talk about one of them. So, oral budesonide suspension, which is swallowed, it's a liquid. This medication helped to achieve histologic remission in about 49% in one study. And it also helped to reduce the dysphagia scores and other symptoms. Endoscopic remission was also observed. And this treatment really long term can really help to reduce some of those complications, which I had mentioned earlier, such as strictures. And so, either way, we do like to follow up with these patients long term and make sure that we are checking their endoscopies as well to confirm remission. And I'd say some of the downsides of topical steroids would be esophageal or oral candidiasis. So, thrush or fungal infections can sometimes occur in a small percentage of our patients taking topical steroids. So, that is definitely something that we would want to monitor for with topical steroid treatment. Next, I'm going to move on to proton pump inhibitors or PPIs. These drugs have been commonly used to treat gastroesophageal reflux disease, and they help to suppress acid in the stomach. And there's data that suggests that it does more than just acid suppression in EOE, that it may also help to reduce some of those changes that I talked about earlier. So it helps to reduce the barrier dysfunction and the histologic response rate from 23 studies was about 42%. Some concerns with PPI treatment would be that some patients don't respond or may not have a sustained response to these medications. And we now kind of look at this PPI responsive esophageal eosinophilia used to be considered its own condition, but we now really consider it to be a subset of eosinophilic esophagitis and not a distinct disease. And so the last of the treatments I'll go over is the biologic dupilumab. And this was approved back in May of this year. It's a humanized monoclonal antibody that binds to the alpha subunit of the interleukin 4 receptor. And so it decreases the signaling pathways of interleukin 4 and interleukin 13. And these are two things that can really increase the allergic inflammatory response. They're called cytokines. So these substances help to increase inflammation. And when we block them and block their signaling pathways, then it helps to really reduce that T cell, type 2 T cell driven inflammatory response that we see in EOE. And so this medication was approved for use in children ages 12 and up. And from my understanding, there are phase 3 trials now going on for ages 1 to 11 as well. And some studies have shown that this drug helps to improve histologic, symptomatic, and endoscopic measures. And so it is very promising and exciting. And again, we hope to better include dupilumab in our treatment algorithms soon in our treatment guidelines as well. And so now I'm going to move on to talking about the relationship between EOE and some of our food allergy treatments. So oral immunotherapy is a treatment that we use for food allergies. And we often get asked the question about the connection between EOE and oral immunotherapy for food allergies. And this is kind of a hot topic that is being studied right now. But I can say that looking at some of these studies, that the incidence of this is less than 3% in our patients undergoing OIT. So it's definitely a very small percentage of our patients. And the other kind of promising news is that this EOE that develops with OIT often resolves after we discontinue OIT and doesn't often persist into a long-term chronic condition. And just briefly, because I know we're coming toward the end of the lecture, I'd like to go over a study that we did with our POISED trial here at the Sean Parker Center. And this study looked at 20 adults with peanut allergy who were on OIT. And we found that the patients who are on OIT, when they underwent EGD or endoscopy, that they had some transient eosinophilia in their gut. And we also found that toward the end of being on OIT maintenance, that this eosinophilia resolved in the majority of patients. And so again, we can see some transient increase in eosinophils in the gut in our patients who have OIT. And we know also that at baseline, many of our food allergic patients may have increased eosinophils. And so again, this is being studied. But this is just some interesting findings from the POISE trial. And so just to summarize our treatment goals, our goals are to help resolve symptoms, help induce remission of the mucosal inflammation in the esophagus, to decrease fibrotic esophageal complications, minimize drug side effects, prevent nutritional deficiencies, and also help maintain quality of life. And oftentimes treatment for patients with eosinophilic esophagitis requires multiple specialists, so multidisciplinary team of allergists, gastroenterologists, and possibly even a dietitian, and shared decision-making with patients to really tailor their treatment and come up with a long-term follow-up plan. And I wanted to go over a couple of non-invasive ways of monitoring EOE. And real quick, I know we're running out of time. Cytosponge is one exciting new method where the patient swallows a sponge and we can collect cells to analyze them, and that can help to diagnose EOE. And again, these are non-invasive. And the second method would be using the esophageal string test, which also is non-invasive and helps us to monitor cells in the esophagus and help monitor patients who are on OIT. And so we have two studies here at Stanford that use the esophageal string test, and that would be our combined strings study, which is looking for markers of esophageal inflammation with the string test, and also our MAGIC study, so MAGIC Spring, which is our OIT study with milk. We are also looking to monitor esophageal inflammatory markers using the string test with MAGIC as well. And I apologize, I rushed through kind of the last half of this, but we have about 4 or 5 minutes left for questions. And I wanted to put the slide up as well in case any of you are interested in our studies. You can give us a call or email us or use the QR code to join our registry. And I'm seeing the first question, the budesonide oral study, is it with peds, adults, or both? So I believe there are several studies looking at the topical steroids. I think the one I mentioned it was in adults. There's also other studies looking at different steroids as well that are topical steroids. And again, I think the one that I had mentioned was specifically in adults, but we do find good outcomes in children as well. And second question is, if EOE is diagnosed based on endoscopy, but patient has no symptoms, would you still recommend Dupixent? And that's a great question. And I really think that's where kind of using the multidisciplinary approach and maybe looking at risks and benefits of all of the treatments that I had mentioned and really monitoring for symptoms and monitoring what's going on in the esophagus would be helpful. So I wouldn't necessarily recommend Dupixent as the first step, but I would want to go through the other treatment options and maybe even looking at monitoring long term, especially if there are no symptoms.
Okay, we have about 2 minutes left. Do we have any other questions? Thank you so much, Josie, for this amazing presentation. Just a quick reminder that we will be skipping our webinar in December due to all the holidays, but we will be picking it back up in January on January 25th. So make sure you mark your calendars. And also, if you want to review this slideshow or this webinar, we will be posting it to our YouTube channel. It's going to be at Sean and Parker Center. Feel free to email us, contact us if you have any other questions. Thank you so much and have a great rest of your day, everyone.
Thank you. Thanks, Kat.